everyone. My name is Nidhi Madan. I'm a second-year fellow at Rush University Medical Center here in Chicago, Illinois. And today we are at the AHA 2018 Scientific Sessions, and I have the honor to talk to Dr. Peter McCartney today, here from University of Glasgow. He's a fellow in training and here to talk to us. Dr. Peter McCartney, it's a pleasure to have you with us today.
Pleasure to be here. Thank you for inviting me along.
Of course. Could you please tell us about the Tea Time trial that was presented today?
Of course, yeah. I'll take that from you. Thank you very much. So we presented the results of the Tea Time trial today at AHA. And I suppose before chatting about that, it's probably important just to talk a little bit about microvascular obstruction. This is what we're trying to treat as part of the trial. We know that treating patients with primary PCI is extremely successful. We get normal flow at the end of the procedure in over 90% of the cases. But there's growing evidence that there's failure of perfusion of the myocardium in up to half of the patients. So if we go on to perform cardiac MRI, we'll find something called microvascular obstruction. So that's an MRI finding, and essentially it allows us to see problems with the microvessels, so obstruction of the microvessels. It's a black area at the core of the white infarct in cardiac MRI, and it's black simply because the gadolinium contrast that we give isn't perfusing to the core of the infarct. It's important because it's associated with adverse LV remodeling, so these patients have larger infarcts, larger LV volumes, and reduced ejection fractions. And when we follow these patients up, there's an increased incidence of mortality and heart failure presentation at a year. So it's prognostically important. It's very common, occurring in about 45% of patients, and at the moment we don't have any treatment for it. One thing we'll often see in the cath lab is no reflow. So when there's no obstruction there, but the flow down the artery reduces or stops. And that can be associated with microvascular obstruction as well. So that's probably what we see more of. So that's the sort of background to the trial. What we did is we recruited patients from 11 UK hospitals. It was a randomized trial, 3 treatment groups, placebo, 10 and 20 milligrams of alteplase. And that's a 10th or a 5th of the normal systemic dose that we used to use for primary PCI. That was given as a slow manual infusion into the artery over 5 to 10 minutes in patients with a high thrombus burden. And the rationale behind the trial was by targeting this thrombus, we may be able to reduce microvascular obstruction. So we presented those findings today, and unfortunately we've shown that intracoronary alteplase had made no difference to microvascular obstruction. And if anything, there was a trend towards an increase in MVO in patients treated with alteplase. We weren't powered for clinical outcomes, but those were directly consistent between the groups. And another primary objective of the trial was to ensure that it was safe and there was no association with bleeding. Again, wasn't powered to look at that, but the number of patients with minor and major bleeds was small, and there was no difference numerically between the groups. You know, I think microvascular obstruction is going to be a tough nut to crack, unfortunately. There's only really been one trial that's shown benefit, and that was a post hoc analysis of a trial of intravenous metoprolol. It was performed in Madrid a few years ago. It has its own limitations. It was a relatively small trial, and microvascular obstruction wasn't the primary endpoint. That was a post hoc analysis. But I do believe that there's plans for a randomized trial looking at intravenous metoprolol prior to reperfusion, and we'll await the results of that when they get running. But I suppose important for us to try and convey is that this is a very common problem. And although we feel that primary PCI is successful in a large proportion of patients, when we look for failure of myocardial reperfusion, we'll find it. And that's important because it has adverse outcomes for the patient.
Sure.
So hopefully we get a treatment soon, but not just yet.
Thank you so much for joining us today and telling us about the Tea Time trial. It's been very helpful. Thank you for listening. For more such videos, please visit us at youtube.com/FitsOnTheGo.